So we have Dr. Karlie here, who is so nice to just sit here and talk about postpartum rehab with us and pregnancy and all that kind of stuff. Everything I know nothing about. Uh, she's a chiropractor, sports chiropractor based in Seattle, been in practice for 10 years, almost everything sports she is an expert on. CSCS, CCSP, correct?
Yeah.
Um, Worked with the volleyball, the pro tour, and all that kind of stuff.
hmm
So, I mean, everything sports, and now you're going into postpartum rehab as well, and dominating that world. So, thank you for being with us tonight.
Yeah. Thanks for having me.
So, let's just kind of get right into it, and let's talk about just kind of like what are the common things that you kind of see in practice with either those who are pregnant or postpartum. Why are they coming in to see you?
Yeah. Yeah. Great place to start. So I think, anyone who's been in practice a while, you see pregnant women, you see postpartum women. If a woman's had a baby, I always like to say she's postpartum is forever. So even if you don't specialize in pregnancy, you're seeing, those postpartum patients. So super important to just kind of understand what's going on with their bodies and what their bodies have been through. Um, I think some of the more surprising things for me once I first started kind of really getting into this world, upper back and neck pain. Any new mom can tell you, especially if she's breastfeeding, super common. They just get so used to kind of hunching over the baby, looking down. Generally, for a lot of women, there's one side that they feed on maybe more than the other. And so there's like, this kind of lopsidedness in neck symptoms. That was one surprising thing that I really do see a lot, and that those patients really benefit from, some thoracic opening, that kind of stuff. And I like to get them started on that before the baby comes and just kind of get them in the routine of, spending 3 or 4 minutes a day, just doing whatever various thoracic mobility piece you want to give them. I find a lot of benefit in that. A lot of the common things, that we all see: sciatic pain, super common. Anterior rib pain, very, very common. When you think about the attachments of all the abdominal muscles into those lower ribs, you can understand and appreciate why, as the belly grows, that pulling, stretching, they'll have a lot of pain, kind of at the kind of top of the belly, lower ribs on the front. Sometimes in the back too, but lots of women don't even really realize that that's rib pain. So kind of by explaining, okay, here's the muscles, these are where these abdominal muscles attach. Here's, how much more they're stretching now. Then they can appreciate that a little bit more. So, of course, low back pain, is very common. And, sacral SI pain, pubic pain, all those things. And then one thing I always just like to remind docs and coaches and whoever I'm talking to is just to remember that the relaxin in the system doesn't just affect one joint. It doesn't just affect the pelvis. It really does affect all the joints of the body. So everything is loosening up. So it's important to consider that with, shoulder issues, neck, even the feet, the addition of weight, the spreading of the feet and the relaxin also can have an effect there. So foot pain can also be pretty common. And I think just remembering that for these women that it's ever changing, because every day they have a brand new body basically. And so I found that it helps to remind them of that like, maybe they have really bad SI joint pain today, but we can help them, feel better, get some exercises to work on stabilizing the hips and getting those muscles to fire a little better, which almost always helps. But also just reminding them like, hey, we'll give you this stuff, but like next week we might be working on a whole new set of problems. So yeah, I guess I just named like everything in the whole body that could hurt, but
I
those are
think
some
you
of the
might have
common.
missed headaches. I
Yeah,
don't. I
yeah,
don't think you
I
mentioned
know.
headaches.
So
So when those, so a lot of those are obviously common things that we see
totally, yeah.
just in clinical practice. How do you, if you do do you change your approach if someone's coming in with, we'll say, just mechanical low back pain or sciatica, or do you treat them basically the same?
Yeah, kind of a little bit of both, right? So I use Webster technique with my pregnant patients. I find that it's something that people know about. I definitely don't think it's the end all be all of aligning the pelvis, but I do find it super effective with the pregnant population. I always encourage people who want to get into working with pregnant patients to take that class, just especially because OBs often know it, midwives, doulas, it's kind of a buzzword. So they know to look for that. So I do use that. I use that with the general population sometimes, but mostly with pregnant patients. As far as like the rehabilitative piece, I think there's just different things we have to look for. I would hope that most of us are probably having our patients squat and deadlift in some form. And it's just maybe a little bit different with the pregnant patient. One thing that I find often is as the pregnancy progresses, some women will have pain squatting below parallel. And so one modification that I find there that's pretty simple is to just bring them up to right at parallel. Also giving them a box or bench or something to squat to seems to be really effective. Again, we might do that with a, non-pregnant patient also, but it's just a pretty common thing I see. Also, single leg stuff can start to become painful sometimes. So women sometimes I'll have them cut out lunges, even single leg hip hinges, maybe step ups, that kind of stuff, and just start modifying with other movements so that they're still engaging the lower body. So important for them to be using their glutes and their hamstrings and the whole posterior chain, of course, still. But that single leg, just the transfer of weight on the SI joints and not having the normal ligamentous stability that they have there, that's one thing that I definitely try to help them modify pretty early on. One thing I found very effective is doing low back holds, kind of the Baron Sorensen, I always say that name wrong, test.
Back extension endurance.
Yeah, exactly.
Make it simple.
I actually find that many pregnant women really benefit from that. Like they come in with pain, SI pain. And if we can get them on there and convince them that it's safe and have them trust us for a minute, that we can get those muscles to fire, it really does, as with many patients, help to stabilize the pelvis. And they'll often get off of the bench and feel a significant change. So much, much more like right away than I see with just kind of the general population. So many women don't have, especially these days, where they're not in their gyms maybe. So maybe they don't have a back extension bench at home. The problem is you can't have them just do like Supermans, right? Because at some point they can't be on their belly.
Right.
The one modification there that I really like is using a yoga ball and having them just kind of prop the feet against the wall and have the yoga ball at the hips. And then they can kind of still get into that extended position. They can have their partner hold them off of the side of the couch or something, but I don't know, pregnant women don't seem to really want to be into trusting their partner with that, it seems like. So the yoga ball,
some stuff could go wrong.
Yes, it's not a time when you want to be falling off the side of the couch or something. But the yoga ball one seems to work really well. And I think just with everything, if we do a good job of explaining why we want them to be in this crazy extended position, hanging off of this ball, but that engaging those muscles is going to be one of the only ways that they can help stabilize their pelvis at this point, and get that buy-in, then that seems to be super helpful too.
You mentioned a couple of times, because I imagine there is a little bit of hesitancy of doing some a back extension hold is a pretty hard thing to do for the average person, let alone if you're pregnant.
Yeah.
And I'm curious because there's probably a safety element, right? I'm sure the first question they ask is this safe for me to do? How do you navigate actually telling them that well, exercise is safe, and particularly this exercise is actually one that'll help you and it's safe?
Yeah, a couple different ways, One thing is with the back extension, I do bring them down. I don't have them extend quite so far, just because it is a lot of, especially as they're getting farther along in their pregnancy, it's a lot of extra pressure through the abdominal wall. So I do often have them come down to a more just slightly above parallel, maybe even at parallel, which is not necessarily how we'd cue, the general patient. When they're earlier on in their pregnancy, it kind of depends on what the hesitancy might be. If they're hesitant again of being like their kind of pelvis on the bench, we can talk about the size of the baby, that it's still down in the pelvis, that first trimester and much, very far into the second one too. So we can kind of talk about that and just explain how much cushioning is in there, so those are some pieces I think that definitely help. And just explaining, as the ligaments are getting more flexible, the only thing we really have to rely on are the muscles. So it's super important that the lateral hip muscles, the glutes, the low back are all firing and engaging. And I think once you can have them try it, of course, you're not going to do this with maybe like a totally deconditioned patient, but we're talking about like maybe an active, pregnant person. So yeah, I think it depends on the person, of course, is like the answer to everything. Right. But those are a couple of ways that I have found to make them feel a little more comfortable.
How would you scale it for somebody who is not as active?
Yeah. I mean, I think the yoga ball one it automatically scales it because they can't be even at parallel. They have to be almost like one of those extended benches that they have in big Globo gyms sometimes that you're like, why is this even here? What is this thing for? Like one of those where they're like, at a pretty severe angle. So it's making it a little bit easier. So the yoga ball one, I find that, and it's flexible, it's not such a hard surface that their pelvis is on. So, I think that automatically scales it right there. So
That makes sense. That makes a lot of sense. And it's also something you could do at home because we're obviously filming during the pandemic. So I think in Washington, the gyms just closed because I know in California, I think they're just closing now in some. So
yeah, they just closed them all again. It's only outside fitness. It's like sideways rain right now. So great.
But at least there's no smoke. So
there you go. That's right. Positive.
So it sounds like your demographic, you treat a lot of like active people.
Yeah.
And when you're going into pregnancy, how do you scale people's like workouts and trying to keep them active and not too active though, if there's such a thing?
Yeah. So, I mean, the guidelines for pregnant women are the same as for the average bear, 150 minutes a week, generally split up, 30 minutes, 5 times a week. And it's like 80 to 85% of pregnant women don't actually meet that requirement. So it's, I think, super important for us, as chiropractors focusing on rehabilitative medicine, sports, that sort of thing, to really express and have some literature behind us to show like, this is why it's important to keep you active. There's so many ways to modify things and it just really depends on what the woman is doing. If we have a runner, everyone is just so different, and I think some women, run all the way into their pregnancy. Like I have no idea how they do it, but some do. And report that they don't have pelvic pain. I think some do it and have symptoms that they don't really realize also, but some don't. So there we'll modify just based on symptoms. In general, I tell people that the first trimester is not much needs to change. The first trimester, generally the issues are that they're feeling sick, tired, fatigued, that sort of thing. Nausea, all day morning sickness, that sort of stuff. So we're more worried about that than like the actual physical piece at that point, because not so much has changed in the body, even though actually the highest levels of relaxin are during that first trimester, which is interesting. But physically, most women can still do most of the stuff that they were doing before. After that, we start to modify some things, notably if we're talking about like functional fitness, CrossFit, boot camps, those kind of things. I like to kind of tell docs that we think of it sometimes a little bit like how a low back pain patient might be. We're going to take out the flexion just because we're trying to resist that excess pressure pressing out through the linea alba, creating more of a diastasis or more coning than we want. We want to kind of try to avoid that as much as we can. Similar things like just in day-to-day life of like not having them like sit straight up in bed, having them scooch to the front of the chair, squat themselves up, like some simple things like that. But so yeah, we're going to cut out their sit-ups, their toes to bar, knees to elbows, any kind of that like flexion, mainly to help avoid just increasing the diastasis and making it harder to potentially recover later. Diastasis, we'll talk about it more here in a few, I'm sure, but is a very natural process. It has to happen, for the belly to expand. Some studies show up to 100% of women have diastasis at 30 weeks of pregnancy. So even if you want to dial it back a little bit from 100%, it's most women. So we just want to make sure that we're not making it worse and we're helping them understand the movements that could potentially just make it harder to recover later.
I think that's a really good pivot just right into, because we obviously we started off with that general like low back pain, sciatica, mid back pain, all that kind of stuff, headaches included.
Yeah.
Let's talk about coning and diastasis recti. Like what is that? What does it mean?
Yeah. So I like to start off the talk with patients about kind of focusing on the coning aspect, because that's the part like during pregnancy that they're going to really want to try to avoid. Things that are going to cause that. We know as docs that it's, that they're losing control of their core basically, and the excess pressure is pushing outward. And the place it has to go is the place that's stretching the easiest, which is that line of fascia along the linea alba. So any overhead movement can start to kind of be one of the things that will cause that, mainly because they're going to lose, as they're losing control, they're going to let the ribs flare up, let the pelvis rotate forward. And that's when that excess pressure is going to be felt through there. So overhead pressing, kipping movements, of course, but also just strict pull-ups sometimes, a lot of hanging from the bar. If they're in a CrossFit gym, that can be something that does cause that pressure and that coning. I always have women try to have someone look at them while they're doing the movements, because many women can't feel it happening. It doesn't hurt. It doesn't hurt the baby. Really, what the goal of not having it happen is to make sure that when they go to recover, when they go to functionally start to heal the diastasis postpartum, we're just trying to make it as easy as can be, So I like to have them have someone watch, or video or something, because then they can really get an idea of like, okay, is this happening? I maybe feel it, but I don't really know. So I think that can be super beneficial. So I start kind of talking about that, explaining to them what it is, also explaining that like, it's not going to hurt them. It's not the end of the world if it's been happening and they didn't have anyone tell them about it, but we do want to make those modifications to make sure that we're not just increasing that as we go along. So that's kind of the during pregnancy part. Often also they can't feel it because the skin is stretched so much. So many women will like think that they don't have it, and then the baby comes out and they're like, ooh, yes, I knew. Because how else, can a small like thin woman, I mean, not even any woman, how can the belly grow so big, So something has to stretch, something's got to give.
Especially without like breaking. Like you would just think that
Totally.
Like with so much, I don't know how much the belly actually expands during pregnancy, like a percentage wise, but like that really is just amazing that it just can
totally
just stretch that far and then kind of come back.
Yeah. I kind of like the rubber band analogy. Some people have used before. I like to use that with patients is, a rubber band is made to stretch, and so that's sort of how like our skin and how the fascia there is too. It's made to stretch, but if we are repetitively over and over and over stretching that rubber band, eventually it's going to get little micro breaks and it's not going to return to the same size it started as. So we can kind of think about that the same way with what's going on with our core is, okay, well, it's supposed to stretch, it's supposed to do this, but let me avoid these things that are going to maybe just be a little too much, so that it makes it just harder for it to return to that same size as it was before. So that's kind of where I start. And then, postpartum, once the baby comes out, that's when we really start with the recovery piece, which is, I think, we want to make sure that we're avoiding stuff during the pregnancy, but then the recovery piece is really where we want to shine as practitioners, because they just really don't, the OBs, the midwives, the docs that are kind of checking them off for exercise, they're not really checking this. Some of them do check, like just the kind of traditional diastasis test that we all know, but they're not functionally looking at it. And I think that's where we can really help them a lot, is by looking at the diastasis postpartum much more functionally than just like, oh, it's, inch gap, too bad, whatever. So
Can you elaborate on what the classical test is for diastasis?
yeah, totally. So the classic test is kind of, patients laying on their back, knees are going to be bent, and then they're going to do just a little bit of a sit up. I usually feel the abdomen before they do their sit up, just to kind of feel what's going on there. Again, remember, this is postpartum. We're not going to worry too much about the diastasis during pregnancy as far as testing. So you'll have them do just like a little crunch. And then you're going to feel basically all the way from their xiphoid process down along the linea alba, down to the belly button, and then just above the pubic bone, basically. So you want to evaluate, kind of usually the standard way is like, by kind of finger breadths, 1 finger, 2 fingers, 3 fingers, kind of the width there. I tell docs to not worry too much about what's happening at the belly button, because we all have a natural separation there. So it's going to feel a little bit larger. So really focusing kind of, a couple centimeters above and below, focusing your attention there. So then you want to note that in your notes, of course. But then what I really like to have people do is do some breath work and see if functionally by using their breath, they can close that gap a little bit. So what that looks like is we have the same thing, same position, but this time we have them take a breath in, and then they're going to breathe out aggressively, sort of like that, as they do their little bit of a crunch. And so you're still feeling kind of along the abdomen. And what you're looking for there is just what happens to that pressure. If breathing out like that starts to close the gap a little bit, that's going to tell you that functionally we can use their breath, we can use transverse abdominis engagement, we can use some of these different tools so that they can relearn to regain control of the core. Some women, when they do that, it will press out into the diastasis, right? And that means we're going to have to do some breath work with them and kind of retraining and take a few steps back to explain what's happening there and how we can kind of use their breath to engage the core and to kind of create that, kind of firm barrel instead of letting that still press out through the anterior portion.
So the idea with that is that when you're doing the retest and they're basically doing like a Valsalva where they're exhaling pretty hard, that they're just engaging more of their core as they're kind of going through that movement, and it helps? Is that?
They're not necessarily doing a Valsalva, because we don't want them we don't want them bearing down. We're actually having them breathe. So we want them breathing out, and also we could cue them to engage the transverse abdominis. So we could say, okay, I want you to try to pull your 2 hip bones together and breathe out, and see if by doing those 2 things, you're basically, kind of engaging all the muscles around, engaging that TA, and helping them to create pressure without pushing pressure out through the linea alba. Does that make a little more sense?
Got it. Yeah.
Yes, they're not bearing down as much as using their breath to kind of transfer down into the abdomen.
You just want them exhaling forcefully,
yeah.
To kind of just get that muscle recruitment.
Mm-hmm.
So let's say that's you do the test, and then you do your modification, and exhaling forcefully helps.
Mhm.
That seems like a direction that you're going to go for treatment wise. And so are
Totally.
you focusing on like breathing first for rehab? Is that what you would, where you would go?
Yeah, yeah. It is so important, the breathing piece in postpartum patients and arguably for all of our patients. But I think like it's a lot for me, and maybe it's just because it's kind of the world I live in, but it's easier to explain and show pregnant women how important their breath is, especially because from what I've seen clinically, so many women, after the baby is like pushing up into that diaphragm for so long, they just lose this endurance of their diaphragm. We all breathe so much with our accessory muscles anyways, right? But so much more for them because they just don't have that area to get that excursion anymore. So I always start with breath work, retraining the excursion, retraining the belly breathing, teaching them generally if I have a patient who starts as, while they're pregnant with me on some of this, we're going to teach them piston breathing, which I'm happy to explain a little more too. We're going to teach them that, and then we're going to use those as we transfer into their postpartum rehab. A lot of the beginning work that we have people do on diastasis is working with that same breathing pattern that we just did in the test. So heel slides, marching, single leg fallouts, kind of leg extensions and lowering is a little bit down the road. But all of these, as we do them, each movement is going to correspond with a breath in. And then as they breathe out, using that breath as the whichever movement is, whichever one you're doing with that movement. So they're definitely going to correspond. And I always just tell patients like, it's so boring and it's so slow and I'm so sorry, but like, trust me, you got to do it. And I wouldn't tell you to do it if it wasn't so important. So yeah.
And especially it's boring. There's no way around it,
Yeah.
right? When especially uh I feel like buy-in can be a little bit challenging when
Mhm.
you're talking about breathing, just because I mean, if we're all talking, we're all breathing. So like
Totally.
it could be easy for someone to be like, how is this relevant? Like there's my breathing is clearly not dysfunctional by any means. I'm still alive.
I'm live. Yeah.
But right? Like, but it sounds like when you pair it with your test retest, that
Mhm.
that kind of helps already build your case, right? Because you're
Totally.
saying, you know, you're having this issue. If we do this, it gets better. Well, I need
Mhm.
to train you to do that more,
Yep.
basically,
And I,
right?
and I think one of the things too, as far as buying goes, also is like there's a very fine line, and especially when you're talking about new moms, right? Like they don't have 2 hours to be doing rehab, and they're not going to spend 20 minutes working on breathing. So you have to make it like 2 minutes, like 2 minutes. I want you to work on lateral excursion of your breathing. And then we're going to use all the breathing techniques that we've talked about in all these little pieces of rehab I'm giving you, but it has to be like the right amount, because some of the rehab plans I've seen out there, it's just too focused on just the breath. And like you said, it's hard to get buy-in. It's easier with this population, I think, because they can feel that like, oh man, my diaphragm, like I can't, it's hard to get a deep breath sometimes. But still we got to make it the right dosage.
Not 30 minutes worth of breathing
Yeah,
every hour on the hour.
that's not going to happen,
Uh,
right?
it's
So
it's a little extreme.
yeah.
Um, that yeah. Hmm. Okay. When you're looking at let's say you have someone who's postpartum, how early into this process would you start this kind of uh, breathing stuff? Are we doing it immediately? Do you have to wait for a little bit for just general healing to occur?
Yeah, I have women start their first week if they have an uncomplicated birth. I mean, even I have had women with C-sections that we start the first week because it's simple, and it's not, I'm not having them run around and do a bunch of crazy stuff. They can start with breathing, and it gives them something they can do, and especially when you're talking about an active, potentially competitive population, they want something to feel like they're a part of their healing process. So I think just giving them these kind of very simple things to start with is great, because for all those reasons. A, they need it, but B, it lets them feel like, okay, I'm actually like, I'm a player in my recovery, you know?
Yeah, I've always it's almost like the exact opposite, but it's with people with that somebody will say like you're going to need a hip replacement, right? And it's just like, but that's a ways out, but like that's in your future, and you feel so helpless because you're like, well, if you're
Right.
not going to like, what am I supposed to do for the next 10 years that you say you're not going to do the surgery for?
Yeah. Right.
Uh, but like in this case, it's like, yeah, these exercises are boring, especially for like, it sounds like with your clientele being like, I was doing snatches, I was deadlifting, I was
Yeah.
squatting with weight. Now you want me to lay on the floor and focus
Yeah.
on my diaphragm? Like, come on, I'm 500 steps in front of this. This is
Totally.
ridiculous. But it
Yeah.
does help them give them something to do to start that recovery
Exactly.
process.
And I think for a lot of women, once I can speak for myself, but I can also speak for a lot of my patients that that recovery is going to be tough. It's like such a wonderful, beautiful, traumatic experience in so many ways, and it's intense, what your body goes through. So, that the recovery is not going to be a walk in the park and you're not going to be snatching 140 pounds next week, but like, it really is like, you feel so disconnected from your body that first week. And so that's another thing that I find is that breathing, even for those competitive athletes that like feel like this is dumb, I want to be doing more, that kind of stuff, like letting them like reconnect and feel like, okay, I can like feel like I'm in my own body again for a couple minutes really does go a long way, because it is just, I think before I had a baby, I like thought I understood, but I really didn't fully grasp like the feeling of like being so disconnected from a body that like, as an athlete, not even as an athlete, but just as someone who like enjoys working out or doing whatever, you get a pretty good feel for what your body can do and how it moves and how things should feel. And when all of a sudden that's so foreign to you, I think that those factors also make the buy-in a little bit easier, because it's like, okay, I know that your body feels foreign. Like this is a way we're going to start to like bring it back to, starting to feel more like you have control of what's going on.
It's simple too, which is the
Yeah,
good thing, right?
totally.
Like it's just very, and I assume like after the whole pregnancy experience that it's probably nice just to kind of sit there for a second and kind of just try to reconnect and
Yeah.
re-engage with stuff, especially like like you said, as an athlete, you're so used to being like, oh, it doesn't feel quite right when I bring my right arm up overhead. Like there's just
Hmm.
something that's just not quite right. And then after, going through pregnancy, all of a sudden it's not your right arm. It's like your
Yeah.
whole body is just kind of like, I don't know what's going on, but like it's just not functioning the way it was.
Yeah, totally. Yep.
Um, so this is actually an interesting question that I thought of as you were talking about this is, so let's say above 90% will have this diastasis, right?
Hmm.
Maybe 100%, whatever.
Sure. Yeah. Yeah.
With other conditions, especially like pre-surgical, we have the whole prehab thing,
Hmm.
right? The stronger you could go into surgery, the better off you are.
Totally.
Are we doing prehab for pregnancy? Does that help kind of with like the whole outcome afterwards as well?
Yeah. So sort of yes and no, right? I mentioned piston breathing earlier. So let me elaborate on that a little bit, because that is one thing that I spend a good amount of time with the pregnant population explaining how it works and why we're doing it. So piston breathing, if I'm not sure how many of the people who watch this will know that term. Wasn't very familiar with it until I started really working with this population. Um, but if you are into weightlifting, you will know the concept, just maybe not the terminology or why we do it. But the idea is basically when we talk about a piston, we're talking about the transfer of force, okay, as we breathe in into the pelvic floor in this case. So the way that I explain it to patients, let me see if I can give you a little better. So we think about our diaphragm as like the top of our pelvic or of our core, right? Quote unquote. And then we think about our diaphragm as the bottom of our pelvic floor. So as we breathe in, both of those move down our lungs fill up with air. And then as we breathe out, they both come up and they contract, right? As we're kind of expelling that air out. So the idea of piston breathing always, but especially during pregnancy, is that we're going to use this kind of natural rhythm of how our pelvic floor and our diaphragm are moving to decrease excess pressure and force that we're putting through the pelvic floor. So the idea is we take a breath in, and then we're going to breathe out at what feels like the hardest part of the movement. So let's take a squat, for example. We're going to take a breath in at the top, and then we're going to be breathing all the way down. But right at the bottom of the squat, we're going to have them aggressively breathe out again, similar to how we were talking about earlier. And what that does is it's just going to cause a little slight contraction of the pelvic floor and just help not put more excess force and pressure down through that pelvic floor than is already happening with the addition of weight and baby and placenta and all these things that are happening. So we want to teach them to use that. And the reason I say that what feels like the hardest part is, like, we know the eccentric load is the hardest part and yada yada. But for the patient, we want to say what feels like the hardest part, or basically where you're pushing out the most pressure. So in an overhead press, it would be right as you start to press. And what that's going to do, again, is just not cause more excess pressure down through this poor pelvic floor that's already, like, sort of getting beat up, right? So I do see that as a sort of prehab, because we're trying to keep them moving. We know that if we keep their pelvic floor functioning and working properly, we're going to help with pelvic pain, low back pain, all those things, right? So that's one thing that I do find really important. Julie Weeb is a PT who talks a lot about this, and I've learned a lot about it from her. She has a lot of YouTube videos. So she's great if you're super into this and want to follow it more. But the reason I say sort of yes and sort of no is, like, birth is, like, God knows what's going to happen, So some women go in and most women have a plan, and it, like, just gets shot, And so we just don't know what's going to happen to the pelvic floor, if they're going to have a C-section, like there's just all these factors. So I think the best thing to do is prepare the pelvic floor as much as we can by using these breathing techniques, avoid overstressing the linea alba and diastasis and causing excessive coning, where we don't need to. And then, like I said, just keeping the hips, the glutes, the low back strong, and having them do core work that's safe, so Palloff presses, like a McGill side plank, there's tons of things they can still be doing that's going to work the core. And we have to remember the transverse abdominis is, such a key player in this population, and transverse abdominis actually helps to push the baby out. So it's important that they're, like, still working these muscles. We don't want to say don't do core, which is, what a lot of pregnant women are wondering, like, can I do core? So we want them doing core. We just want them doing the right stuff. We don't want them doing their crunches. We don't want them doing, some women can do planks early on, but anything that's, like, pushing that pressure down. So that was a long answer to, like, a question that I don't even remember what the question was. So
No, it makes sense. I mean, just like you said earlier, like, it totally depends on the person anyways, right?
yeah,
Like,
totally.
if you have someone who is going in deconditioned, like, it's going to be a harder uphill battle as you're kind of going into pregnancy,
Right.
versus someone who has been in the gym quite a bit, and so, like, they're looking to kind of more, I guess, maintain
Mhm.
versus build over a
Right.
9-month period.
Yeah, it's not a time for building, like, the goals are just so different. The goals are now, like, these things we're talking about, right? Healthy baby, of course, healthy mama, mentally and physically, and so it's a hard time if, when I have patients that come in and they've been, especially, like, maybe working on losing weight, or they felt like they should have lost more weight, or they should be getting stronger. I'm like, sorry, sister, now's the time when we're just kind of maintaining, and we have to have this mind shift of goals. And then, we can talk about new goals after baby comes, if that's the case. But yeah, it's just a total, like, mind shift, so.
So you were very generous with your time, and,
Thanks.
like, I think we've covered quite a bit of stuff. Um, what would be your biggest takeaway for students, practicing docs, for both working with pregnant populations and then as well as postpartum?
Yeah, I think one of my like biggest things I'd like them to understand is the importance of the breathing work. I just like I could not buy into the breathing stuff for so many years. And I mean, I wanted to, but I just couldn't like find good ways to explain it to the patients. So I think, using some of these ways, I found much more buy-in and like letting them like feel the difference. And then of course I'm buying in more too, because I like see the changes and how these women are moving, and how their body is responding to the breath work. So I just think I'd really like to stress that it's so important. Squatting, keeping our pregnant women squatting is also super important. Even teaching the ones that don't know how to squat, because we know like giving birth, you give birth in a squatting position, whether you're actually squatting or they're laying supine, sorry. Um, we it's so important that we're teaching them. It doesn't necessarily mean that we're like loading them up with weight, but we're teaching them proper squat mechanics. That's going to serve them for a whole lifetime, of picking up their kids, bending over for things. So teaching them to squat and deadlift, I think, is so important, even if we're not teaching them to do that with weight, so just not forgetting that like these women are still, even though they're pregnant, they're like, still capable of many things and still should be moving and still should be exercising. And yeah, I think that's like one of the things that is most important, and that there's so much they can do postpartum to recover, and we can help avoid, we all see the patients, that have low back issues, pelvic floor issues, all stemming from their birth and not doing anything, not realizing they should do something, all that stuff, many, many years ago. So I think that's a space where we can really help them so many ways in the long run.
That's a really good point, especially like there's so much stuff that goes on after pregnancy, right? In that first year, that
Hmm.
spending a little bit of time on yourself to kind of help get yourself healthy afterwards as well in that recovery process, working on the breathing, working on the strengthening aspects and all that kind of stuff. So that way, longer term, you don't have chronic low back pain, chronic abdominal issues and all that kind of stuff because you
Totally. Yeah.
missed that window where you had everything else going on. You got to care for the kid, get back to your
Yep.
life and all that kind of stuff. The last thing you think about is how many glute bridges should I do today?
Yeah. Well, and this is
You
the
know?
reason that I created a postpartum plan for women for this reason, right? Because the stuff that was out there, the plan I bought and did, I thought it was good, but I just kept adding in, the stuff that we give people every day. And I was like, okay, well, this should just be a thing. So I created it and made it so it's like, okay, it's 4 times a week, it's 15 to 20 minutes. Still, most postpartum women don't get those 4 days a week, but they stretch it out over, 2-week period or whatever it is. But it gives them this like timeline of like, okay, this is like where I should be or where I could be. And then it just gives like a, kind of a blueprint. And then of course, maybe they move faster, maybe things are much slower. It depends on if they have multiple children, of course, and like their time and all that stuff. But I think it's important to realize that like most women should be doing some sort of recovery. We wouldn't have someone have a different sort of surgery and just do no recovery, So while it is a natural process and it is something that the body is made to do, we just have so much knowledge about how we can return to play basically earlier, with all that we know. So we should be helping them to do that.
So tell us where people can find that plan. And
Yeah,
then also, if you're on social, how do people get in contact with you if they have more questions
totally.
for you?
Yeah. Yeah, so I'm on Instagram at Dr. Karlie, just DR and then Karlie. Um, All the bunch of the videos are on my website. So on our YouTube, I just upload them. So there's like 2 views, but Seattle Sports Chiropractic and Rehab on our YouTube page. So you can check those out. The postpartum plan is on karliecausey.com. So you can check that out there. There's a link from my Instagram also. And I can also, if we want, Michael, I can put, we can do a discount code for the docs that watch this if we want. So if they want to buy that, to use it, I'm also making a code that I'll put on my social media, but that you can buy as gifts for your patients. So it'll be significantly reduced so that if you have, patients who are pregnant that you want to like gift them this plan, it'll be about half price for you to buy it to give to them. So, but you have to buy it in like a little bundle of 3 or something. So that will be out soon too, but we can put a link with a code, for a discount as well.
Perfect. That all sounds really good.
Cool.
Again, thank you, Karlie, for your time. Really appreciate it.
Yeah. Thanks for having me. It's good to chat with you.